So once you've done the lung, what are the physiological changes can happen in the patient's lung when you initiating the positive pressure mechanical ventilation. Going to the next organ, it is called positive pressure ventilation and the central nervous system. There is something called dangerous crosstalk. Okay, the organ dysfunction, for example, the brain injury can cause acute lung injury. Because of this brain injury can release the inflammatory markers. These inflammatory markers can cause lung injury, or the treatment of this acute brain injury like barbiturates, if excessive barbiturates can cause aspiration, or it can cause aspiration and the aspiration pneumonitis. The acute brain injury can cause low GCS, can aspirate and cause lung injury, or it may be a hypothermia. Sometimes it can use for the brain protection. All this hypertension or hypervolemia or neuromuscular blockage to decrease the ICP, all this can cause acute lung injury. The second thing, the lung injury itself can cause brain injury. See here, if it example pneumonia, because the pneumonia, atelectasis, sometimes neurogenic edema because of the acute brain injury, this pneumonia or atelectasis can cause hypoxia, sometimes hypercarbia. The hypoxia can cause brain injury, sometimes hypercarbia can increase your ICP. Sometimes this positive pressure mechanical ventilation can decrease the venous return, so it can increase the ICP. So it's all these organs are interdependent. If the acute brain injury, positive pressure mechanical ventilation can cause or worsen the brain injury, or brain injury itself can cause lung injury or can worsen the acute lung injury. Some of the things to that, if I protect that, so our aim of the positive pressure mechanical ventilation in the patients with central nervous system injury, it may be a traumatic or stroke, your aim of the mechanical ventilation is to protect the two organs. You have to protect the lung also from the ventilated lung injury. You have to protect your brain also. The brain protection depends upon three things. One is the cerebral blood flow, it's intracranial pressure and the cerebral perfusion pressure. I have to ensure that adequate cerebral blood flow. I have to keep my intracranial pressure in the lower range, a normal range. I have to keep the perfusion pressure at 60 millimeter mercury. If sometimes the mechanical ventilation or our respiratory failure can worsen or can alter this protective mechanism. Example, the hypercapnia can cause vasodilation, it can increase your ICP. Sometimes hyperventilation, for example, hyperventilation or hypoxia, hyperventilation can lead to vasoconstriction. It can decrease the perfusion to the already damaged brain tissue. It can cause the brain injury. So our aim is to protect the lung and also protect the brain. Okay, whenever we initiate in the mechanical ventilation in the patients with acute brain injury, a lot of false beliefs are there. There is first belief is that the brain and lung is, if example the brain injury won't cause acute lung injury, the acute lung injury won't cause brain injury. It is not true. It's very common if the patients with brain injury can develop some amount of lung injury also. The second thing, you have to be a more oxygen, you have to set a higher SpO2 range or SaO2 of the patient having brain injury, but it is not true. Okay, if excessive oxygen brain injury, example excessive oxygenation, example hyperoxia itself can cause free radical release, it can cause organ dysfunction. So you have to titrate your FiO2, achieve a target saturation of 95 is acceptable. There is a common belief is that you have to set up 0 PEEP, so it can prevent the ICP rise. One. The second thing, you have to set a high tidal volume, so it can wash out your CO2, PCO2, so it will decrease your ICP. But it is not true. Okay, so 0 PEEP must be avoided. The PEEP should be enough. Okay, it's optimal PEEP is important. If example, I am giving a 0 PEEP in the patients with ARDS, what will happen? The patient will have the hypoxia. There is a poor lung complaints. What will happen? I have to give a high pressures to maintain a ventilation. If it is a hypoxia and that high tidal volume, hypoxia will cause brain injury. High tidal volume will cause that excessive inflammatory marker, release inflammatory, it can cause a brain injury. No, there is no point of setting 0 PEEP in the patient with that raised ICP. You have to set a optimal PEEP. Okay, for example, it is the PEEP, the change in ICP when you are setting a PEEP based on the PEEP, it not only depends upon the PEEP value, it depends upon what are the changes the PEEP making in the patients with lung mechanics. For example, when I is increasing the PEEP, it's opening a new alveoli, the compliance is increasing, oxygenation is improving. That means that is the PEEP, that PEEP, it actually will decrease your ICP. Okay. So, for example, if I increasing the PEEP, that PEEP causing over distension, it worsening the lung complaints, it can harm the patient, it can increase your ICP. So it doesn't mean that the 10 pp is good, 15 pp is harm. Sometimes the 15 pp is the patient, the lung need the 15 pp. They have to set a 15 pp. Okay. Then only it can open a new alveoli, it increase your compliance, it increase your oxygenation, it will cause the better ventilation, so it can decrease your ICP. So always set a PEEP, optimal PEEP, not 0 PEEP. Second thing, the tidal volume must be high. Brain injury patient, it is not true. Okay. If I set a high tidal volume, it can cause more ventilated lung injury, it can release a more inflammatory markers, it can cause more brain injury. Okay. Always do a hyperventilation must be done. It is not true. Always keep a PCO2 in the normal range. You can use a hyperventilation as a rescue. Okay. If the patient having a life-threatening ICP rise with brain herniation, you're going to ship the patient to OT for a decompression. In those settings, we can use a hyperventilation as a rescue for the short term. The second thing is a recruitment maneuver should not use in patients with acute brain injury patient. But it's not true. Okay. If example, the patient is having a severe ARDS, oxygenation is not maintaining with a PEEP and whatever the all lung productive ventilation, they can try. If example, saturation is 50 despite of all your measures, lung productive measures, in those settings you can try a recruitment maneuvers as a rescue. Okay. If example, if you not done a rescue, the 50 saturation obviously going to cause brain injury. Okay. So in this settings you can use a recruitment maneuver as a rescue with appropriate neuromonitoring. The second thing, assisted ventilation is not contraindicated. It is not true. Assisted ventilation is allowed. Okay, with acceptable PaO2 and PCO2. Okay, the extubation should be delayed. It's not true. Tracheostomy should be performed at the late. It is not true. The prone position is not contraindicated in a prone ventilation. Can increase your ICP, but there is patient is hypoxia, you can try prone position with appropriate neuromonitoring. The ECMO has thus no role. Okay, there is no things that this should be done or this should not be done in our brain injury patient. All our lung productive ventilation should be applicable in the patients with brain injury also. If you do some of the rescue maneuvers like ICP or using excessive PEEP, you are going to prone patient, I think you have to use the appropriate neuromonitoring, which is very important.